Ajwa, please, what are your expectations for today's webinar? Well,
Hello, everyone. Please can you hear me?
please, we can.
Yeah, I'm expecting to be enlightened on this whole concept of sickle cell and clear any misconceptions. Yeah, right now. Thank you.
Okay, thank you, Ajwa. Mustafa Osman, please, what are your expectations for today's webinar?
It's my wife, I think, is the first speaker, so I'm here to support.
That's nice. You're welcome.
Thank you.
Okay, good afternoon once again, and we are all welcome to today's webinar titled We Are Both AS. Can We Get Married? Today, we are here to demystify the sickle cell disease. Any rumor about the disease? My name is Sarah Uzupuke, and I'm honored to be the moderator for this important conversation. Sickle cell disease, as we all know, is one of the most genetic conditions that is talked about, yet it is one of the least understood topics. So today we'll explore what it really means to be an AA, an AS, or an SS genotype. And to do that today, we have three outstanding speakers who bring medical knowledge, advocacy, and practical life experience to today's discussion. Okay, so before we begin, kindly mute your microphones unless they are speaking. And if you have any questions, please do well to drop them in the in the chat box, and we'll address them during the question and answer section. So our first speaker, Miss Aisha, is a fifth year medical student currently studying in Egypt. She is a proud Ghanaian and a cardiology aspirant with a strong passion for research. She is deeply committed to health education, especially in areas like first aid, disease prevention, and mental health advocacy. For today's webinar, Ms. Aisha will walk us through what the sickle cell disease is, some potential triggers, and why this topic is important. Ms. Aisha, please over to you.
Hello, everyone. Good evening to you all. Thank you so much, Miss Sarah, for this warm introduction. Can you all hear me, please?
Yes, please, we can hear you.
Okay, so I'm currently having issues with um projecting my screen. So okay, I'll have to. So sorry. Hmm. Can you all see my screen now?
Yes, please, we can.
Okay. So, thank you all for your patience. Let me begin this session with a question. This question has echoed through the hearts of many couples. I'm told my WhatsApp is visible. Okay.
Hello, Aisha. Good afternoon. Allow me to slightly interrupt you. Kindly share your slides with me. It's difficult for us to see you so that I can project it from my end. Thank you.
Okay. Hello, everyone. Can you all hear me, please?
Aisha, I'm also having challenges here. So if you go ahead, I'll make sure I rectify it.
Hello. Can you hear me, please?
Yes, please, we can.
Okay. Thank you so much for your patience. And I'm really sorry for the technical issues. Okay. I would like to begin this session with a question. This question has echoed through the hearts of many couples, especially couples in Africa. This question is more than science. And then the question, as our moderator has already asked, we are both AS. Can we get married? I'm sure a lot of people have asked, a lot of couples have asked each other these questions. This question is, it seems like it's more of genetics, it's more of science, right? But then it is not limited to science. It encompasses fear, love, culture, hope, and even the future of the families. Imagine falling in love with someone, right? you begin to plan your future together with your significant other, and then one day you wake up only to discover that that person, you wake up one day to discover that a single blood test could change your future. It could change your destiny. So I'm here to tell you that whether you are AS, AA, SS, or you don't even know your genotype, this session is actually for you. So let's begin by decoding the science, embracing the emotions, and answering one of the most important questions in modern relationships, which is, can love survive a genotype? And how can knowledge protect the next generation? I have a couple of statements that I want to share with you all. I want it to be in a form of an engagement. I make this statement, say I mention a statement, right? Then you indicate in the comment section whether the statement is true or false. I want this to be an interactive session. So you use T to indicate true. You use T, the letter T, to indicate true, and then the letter F to indicate false. So let's begin. If you are AS, you are sick. Is this statement true or false? So please indicate in the comment section. I'm reading. Let's make this interactive, please. If you are AS, you are sick. True or false? I'm not seeing your answers. So. Okay, I can see a couple of Fs. All right. Okay. So the next question is, two AS people, two AS couple can never marry. True or false? Okay. I can see a couple of Fs. The third statement is, sickle cell only causes pain and nothing else. True or false? Okay, I can see a couple of Fs. The final question is, the final statement is, children with sickle cell disease don't live long and cannot have a normal life. True or false? Okay, I see a couple of Fs. Thank you so much for answering. Well, I wouldn't share the answers with you now. I want you to be your own examiners. I want you to be your own and to mark your own answers. So by the end of this presentation, I am sure, 100% sure that all of you will be able to mark yourselves. So the outline of today's presentation. By the end of this session, or by the end of this webinar, each and every one of us should be able to tell or should be able to know what sickle cell disease is, the most common types of sickle cell disease, as well as the sickle cell traits, the signs and symptoms of sickle cell disease, potential triggers for sickle cell crisis, how sickle cell disease is inherited, emotional and cultural dilemmas, options for at-risk couples, and you have a couple of key takeaways. Why does this topic matter in the first place? What do you think? Why does this topic matter? Well, sickle cell disease is one of the most common inherited blood disorders in the world. Around 300,000 babies are born with sickle cell disease each year globally. The number is 300,000 babies. Many of these cases are preventable through awareness and informed decisions. In low-resource countries, 50 to 90% of children with sickle cell disease die before the age of 5. In low-resource countries like Ghana, of course, children 50 to 90% of children with sickle cell disease die before the age of 5 due to lack of diagnosis and treatment. But in high-income countries, people with sickle cell disease can live into their 40s to 60s with proper care. What is sickle cell disease? So sickle cell disease is an inherited blood disorder where red blood cells are abnormally shaped, typically crescent or sickle-shaped, due to a genetic mutation affecting hemoglobin. So let's just imagine a blood vessel. Blood vessels containing blood, just like the pipes in our various homes that distribute waters through the taps. So the pipe, we have a pipe and then we have water in it. That is the same way that we have blood vessels with blood passing through them. So we have different sizes of blood vessels. We have the very large ones, the medium-sized ones, the smaller ones, and then we have the minute ones. So the shape of the red blood cell, the blood has a liquid part of it and then cellular part of it. That is the part that is made of cells. Among these cells, we have the red blood cells. These red blood cells, they have a protein known as hemoglobin. The hemoglobin helps with the red color of our blood. And this hemoglobin, this protein, it transports, the protein transports oxygen to our tissues, all our body parts. So normally, the red blood cells, they have this disc shape, the compact disc, the CDs we used to watch movies back in the days. They have the same or similar shape. The middle part or the central part of the red blood cell is very thin, but then the edge is very thick. Why is this shape necessary? Why is this shape important? So that we call it the biconcave shape. This enables the red blood cells to fold up if they want to pass through narrow blood vessels. So let's look at the other cell on the screen. There is another cell, red blood cell, that is sickle-shaped. It has the shape of the crescent. This red blood cell cannot fold up. It is as it is. And then it is very fragile. This occurs as a result of abnormality in the hemoglobin. So there's a genetic mutation or genetic abnormality in the hemoglobin that makes the cell assume this shape. So let's imagine cars on a highway, right? The cars on a highway, they move freely. But once a car breaks down in that highway, the rest of the cars behind that broken car cannot move ahead. There will be a traffic jam. That is the same way or something similar happens in the blood vessels of sickle cell patients. When this abnormal red blood cell, which has a sickle shape, when it blocks the blood vessel, because it cannot fold up, so it will end up blocking these smaller blood vessels. So the rest of the blood cannot be transported. In other words, oxygen cannot be delivered to our body parts, right? So all these our body parts wouldn't have oxygen, but it depends on the particular blood vessel that is going to get blocked. So if it happens to be the blood vessels that supply your legs, that means your legs are not going to get oxygen and there's going to be problems. So what are the types of sickle cell disease? We have various types of sickle cell disease, but the two most common types are the hemoglobin SS disease and then the hemoglobin SC disease. The hemoglobin SS disease, with that one, the people with the hemoglobin SS disease, they inherited one gene encoding hemoglobin S from each of their parents. This is the most severe type. And then we have the hemoglobin S. People with the hemoglobin S form inherited a hemoglobin S gene from one parent and another abnormal type, which is the hemoglobin C, from their other parent. This one is milder as compared to the hemoglobin SS. And then we have the trait, who is also known as the carrier. So they are the hemoglobin AS. So people with sickle cell traits, they inherited a hemoglobin S gene from only one parent and a normal gene from the other parent. So they are AS. They do not have the disease. They are only carriers of the disease. That is, if they give birth, they are capable of they are capable of transferring the abnormal gene to their children. But they personally, they do not have the condition. So they do not have the signs and symptoms of sickle cell disease. They are just carriers of the gene. Let's look at the potential triggers for sickle cell crisis. So we have sickle cell crisis. It's a couple of crises. I wouldn't mention the crisis in order not to overwhelm people, especially the non-medics, right? So I will just mention the signs and symptoms. But before I mention the signs and symptoms, these are the potential triggers of sickle cell crisis, the sickle cell signs and symptoms. When a sickle cell disease patient or sickle cell patient is dehydrated, this can trigger the sickle cell crisis. So the sickle cell patient does not have enough fluid in their system, probably because they haven't taken a lot of water or they have sweat a lot. Anything at all leading to dehydration can trigger sickle cell crisis. Another thing is cold temperatures. When the weather is cold, this can trigger sickle cell crisis. We have stress, low oxygen levels, infections, surgery or illnesses can all trigger sickle cell crisis. The signs and symptoms of sickle cell disease. I've already mentioned previously that the signs and symptoms are as a result of the blockage of the blood vessels, right? So depending on the blood vessel that gets blocked, then the signs and symptoms. So if it is the blood vessel that supplies the eyes, then there's going to be visual problems. If it is the blood vessel that supplies the joint, there's going to be joint pain. If it is the blood vessel that supplies the legs, there are going to be leg ulcers, bone pains, depending on the site that gets blocked. Another thing is that I mentioned earlier that the red blood cells, the sickled red blood cells, are very fragile. So they are very liable to breakage. And when this red blood cells, they are the major components of our blood. When they keep breaking down, the patient is going to have anemia. There's going to be low hemoglobin. That protein that carries the oxygen is going to be low. And so the blood of the patient is going to be lower, way lower than it should be. And so there are going to be signs and symptoms of anemia, which includes fatigue. Very little activity is going to make this patient very fatigued. And there's also yellowing of the eyes as a result of what? The breakage of the red blood cells. So when red blood cells break down, they release certain pigments, right? These pigments are responsible for the yellowing of the eyes, including other mucous membranes and then the skin. We have delayed growth because the blood is not able, blood transports oxygen as well as nutrients. So if the blood is not able to reach the tissues wouldn't get nutrients for proper usage in order to utilize these nutrients for growth and then development. And there is frequent infections because the immune system is going to get depressed. And so the body is going to get liable to infections. There is also prolonged painful erections in men because the blood vessels supplying the penis with blood wouldn't be able to supply the penis with blood. So there's going to be prolonged and sustained erection, which is very painful. It is known as priapism. It is very painful. Now we have the complications. I've already mentioned a couple of complications. So if the blood vessels that it supplies the brain gets blocked, there's going to be stroke. If it happens to the kidney, there's going to be kidney failure. If it happens to the lungs, there's going to be lung problems and then breathing problems. And yeah, I already mentioned the infections as well. So treatment of sickle cell disease. Sickle cell disease, there is a cure for sickle cell disease. That's the good news, right? But the cure is not easy at all. So with the treatment of sickle cell disease, I would like to begin with the supportive treatment. We have curative treatment, that is definitive treatment. When this treatment is done, the patient is going to be cured. And we have the supportive treatment or the preventive treatment. This treatment is not curative. It's just to manage the signs and symptoms for the time being. It doesn't cure sickle cell. So among these supportive treatments, we have hydroxyurea, which prevents the pain. We have blood transfusions because there's going to be chronic anemia. So there is a need for blood transfusion. There is pain management analgesic painkillers to control the pain, because the pain in sickle cell disease is unbearable. So there's a need for pain management and infection prevention, because we already learned that sickle cell patients are very liable to infection because they have depressed immune system. So there's a need for infection prevention through immunization and also preventive, we call it prophylactic antibiotic treatment. So preventive antibiotics, you use antibiotics to prevent the occurrence of infections. Now, we have the curative or definitive treatment. We have stem cell transplantation and gene therapy. In as much as this is a good news that sickle cell has a cure, but then how many of us can afford this, especially a typical Ghanaian man or woman? We cannot afford this. Mind you, the stem cell transplantation is very expensive. It is in the hundreds of dollars, $100,000s of dollars. Sorry. And that one, it even requires a perfect match. If you don't have a perfect match, you cannot have a stem cell transplantation. And then there are risks associated, just like other treatments. There's a possibility of acquiring an infection from stem cell transplantation, and there's even a possibility of rejection after all the stress of getting a donor and everything. You'll still get the transplant will still not be successful because there's a rejection. We have gene therapy. Gene therapy is also a very good news. It happens in the lab. They take the abnormal gene, then they modify it and they know what they do to make the gene a normal one, and then they take it back into the bone marrow. Then it starts to develop normal red blood cells, and then there will be no longer the sickled shaped RBCs. This is also a very good news, but it's even way more expensive than the stem cell transplantation. It's in the millions of dollars, so you can imagine. And even with that one, there are also risks involved, because there's going to be chemotherapy before all these. So the immune system is going to get so suppressed, so depressed, and it brings a lot of complications as well. So in as much as there is treatment for sickle cell disease, you have to think twice. Can you afford it? And will you get a donor or not? This brings me to the end of my presentation. My colleague, Miss Millicent, will take over from here. Thank you very much.
Thank you very much, Miss Aisha. That was very enlightening, and you've laid a good foundation. Moving on, our next speaker is Miss Millicent Ajiman Bedu. She's an accounts personnel by profession and a dynamic health advocate. She's also a virtual assistant and an entrepreneur, using her platform to raise awareness about health-related matters, and she helps support others in managing their wellness. She'll be taking us through how the disease is inherited, its implications, and some real-life stories. Miss Millicent, please, you have the floor.
Okay. Um, Thank you so much, Miss Sarah. And I just want to say a very big thank you to RTC Foundation for giving us the platform to create this awareness. So I'll start with how SCD is inherited. So sickle cell disease is inherited in an autosomal recessive pattern, which means a child must receive one sickle cell gene from each parent to have the disease. This inheritance pattern is the same with every pregnancy, regardless of previous outcomes. If one parent has the sickle cell trait, which is the AS, and the other is AA, which is like the parent is very normal. None of the children will have the SCD, but there is a 50% chance that each child will be a carrier. So when you look at my right-hand side, there's a diagram that demonstrates how a normal person and a person or another person or another parent who is a carrier of the sickle cells. So when you see the father and the mother, it means that when they give birth to a child, the child will inherit the gene, which is the A, from the mother, and then carry another A gene from the father. So the child will become a normal person. But when they give birth to another child, that means that the child will carry the A gene from the father and the S gene from the mother. That means the child will be a carrier. And then when they give birth to another child, it means that the child will inherit the A gene from the father and then the A gene from the mother. That means the child will become a normal child. And when they give birth to another child, it means that the child will inherit the A gene from the father and then the S gene from the mother. It means that the child will become a carrier too as well. So that's the reason why I said that when one normal parent marries someone who is a carrier of the sickle cells, it means that there's a 50% chance that each child that they give birth to will be a carrier, as demonstrated earlier on. So when you take a look at the inheritance pattern, that's the Punnett square, it means the inheritance pattern, the Punnett square. Next slide. Okay, so this one will be easier. This one talks about when two individual AS get married. So most of the times we the ladies, we like the pink color. So I'll use the pink color to represent the mother and then the blue color to represent the father. So when the father is a carrier, which is the AS, and the mother is also a carrier, which is also AS, it means that each pregnancy that they carry, there's a 25% chance that the child will have the disease, right? So when you take a look at the Punnett square, it means that when they give birth to a child, the child will inherit A from the father, which the color represent, the blue color is, and then he or she, the child, will also inherit the A gene from the mother. That's the pink color. When they give birth to another child, just in case that the first child, so it could be that the first child can have the sickle cell disease. There's a probability. That's the reason I said that there's a 25% chance that the child will have the disease. And there is a 50% chance that the child can also be a carrier. And then there's a 25% chance that the child can be a normal child, can move around without having the disease. So that's the reason why the child will have the AA. That's the A from the mother's gene and the A from the father's gene. And then that child also, another child can also inherit the A from the father, which is the blue color, and the S from the mother, which is the light pink color. So when the child or when the mother also carries another pregnancy, it means that that child can inherit A from the mother gene, which is the pink color, and then S from the father's gene, which is the blue color. And there is another possibility that when they give birth, that pregnancy that the woman will carry, it means that the child will carry the S from the father's gene and another S from the mother's gene. And then this makes the child inherit the disease. This makes the child have the disease. And then if the child have this disease, what will be the implication? So it means that the risk repeats itself after every pregnancy. It doesn't mean that when the mother gives birth, or the child will be normal. No, it doesn't mean also that the first child can be normal. No, that's the reason why I said there is a 25% chance that the child can carry the disease, or the child can have the disease, or there's a 50% chance that the child can be a carrier or will have the trait, and then there's a 25% chance that the child can be a normal child. So there are implications of having a child with an SCD, one child. So there are 4 implications. And then they are the health implication, emotional implications, the financial cost, and the family strain. The family strain that's where decision making takes place. Who will take care of that one child with SCD? Imagine in Ghana, many of us are middle earners, like middle income earners. So imagine, would you be able to go and take a nanny to take care of their child? And then that's where the decision would take place. Who is supposed to take care of the child today? Is it the father or the mother? So there are implications inside there. So when you talk about the health implications, it means that with the health, emotional, and financial, I will combine both together so that you really understand how the implication goes about for having just a child who has the disease. So the health implication is when there's a frequent hospital visit from pain crisis. And then, as I initially said, Ghana, let me use 70% of Ghanaians are middle income earners. How would parents be able to get money to visit the hospital frequently? Imagine the medication. The medication is not only one medicine. There are bunches of medication that the child is supposed to take each and every day. Lab tests that these parents is supposed to do on the child, the blood, the transfusions, the hospital admission. And then when this child is having the pain crisis, you're not saying that you're going to take Chusky. It's not possible because you're in a rush. So you're supposed to take either Uber, right? That we have Uber, Bolt, Yango, and then probably maybe a taxi to transport this child from the house to the hospital. How much would you get every day to do so for having this child to become a better or to get well a day or probably a month? So that's where the financial implication comes inside. And the indirect cost is when probably, I want to ask my audience, if you are an employer and then you found one employee who is giving excuses each and every day that I have to take my child to the hospital, I have to do this, I won't be able to come, the excuses. If you get a good boss, that's fine. Your boss will favor you. But in case probably the head there's how do I put it, job loss, right? You missing work every day, and then at the end you lose your job. And if you lose your job, would you be able to save? So probably when these two individuals, AS get married, and then they have plans that, oh, probably we have a building projects to do, and then bam, you have a child with SCD. All these visions will be shattered. You're not going to have investment. Every time you have reduced savings, you might need assistance from other people in taking care of the child. And then let me talk about the emotional implications. They are stress. The child is being bullied. Why? Because there's a delayed growth in puberty. There is fear, there's anxiety, both the parent and the child. Imagine your child is not going to school. When you ask him or her, why are you not going to school? Why are you not excited? to go to school, and then the child will tell you that my friends or my colleagues are bullying me, I'm being bullied at school. How would you, the parent, how would you feel for that? So these are the emotional implications and the health implications, and then the financial implications of having one child with SCD. Siblings, maybe probably you have other children who do not have the diseases, but they are just carriers of they are just carriers. They will be neglected. They will say that, oh, mommy and daddy, their attention is only on Ajwa or Kwejo. They don't have attention for us. So imagine all these things just of having a child with a CD. So I will move to the real stories that I myself have encountered. So I will just use Ama and then Kweku for the two stories that I have. So Ama most of the time says that the girl who refused to break. So Ama was diagnosed with sickle cell disease at 6 months old, growing up in a small town in Ghana. The episodes of having pain crisis would leave her bedridden for days. School became a challenge, missing classes, being labeled fragile by peers, and enduring endless hospital visits. At age 16, Amma made herself a promise. I will not let this disease define my story. She started a blog sharing her experiences and coping mechanisms, which eventually attracted the attention of a sickle cell advocacy group. Today, at 26, Amma is a public speaker, health advocate, using a voice to educate young people living with sickle cell about self-care, resilience, and the importance of routine checks. So that's the first story. The second one is, I don't want to mention the person's name, but I'll just use Kweku to represent him. So he says that from hospital beds to hero. Then it's true. Kweku was told he wouldn't live past his teens. His childhood was marked by frequent blood transfusions and multiple bouts of acute chest syndrome. But Kweku was a fighter, despite being in and out of hospitals. He graduated top of his high school class. At the university, Kweku faced new challenges, late night crisis, managing medications, and balancing studies. Through Seawall and then a supportive cycle of friends, he completed his pharmacy degree and now works with a pharmaceutical company conducting research on affordable sickle cell treatment. His message always is, hope is a medicine too. So I just have questions for my audience. Do they have any real life scenarios that they have seen, they would like to share? Maybe they can just put it in the comment section, and maybe an experience that they have encountered with an SCD patient. So thank you so much. I'll end my presentation here. Thank you, my audience, my moderator, Ms. Sarah, Dr. Benedicta, and I will hand over to you. Thank you so much, my moderator. Thank you all.
Thank you so much, Miss Millicent. Moving on, we'll dive into the emotional and cultural dilemmas of the disease, some options for couples who are at risk, and some key takeaways. And to do that for us is Ms. Joyce Aframa Asamoah. Ms. Joyce is an antimicrobial resistance advocate, and she is currently a fifth-year pharmacy student at the University of Health and Allied Sciences in Ghana. She is also an entrepreneur. Ms. Joyce, please take us away.
Thank you so much, Miss Sarah. After everything we have heard from my two colleagues, we can all attest that there's definitely going to be some sort of dilemma, both emotional and cultural dilemma. People are going to be torn between love and their genotype. Should I follow love or I should follow my genotype? This is a very difficult decision. And some questions that these couples at risk face is, should I leave someone I love because of genotype? What if I find out after engagement or marriage? What then do I do? And it's especially daunting when it's accompanied by pressure from family, pressure from society, and also from religious bodies. Next slide, please. For family, in many cultures, marriage isn't just a union between two individuals. It's seen as a union of families. Families may pressure couples to stay together because of probably a long-standing relationship or bride price payments or even their community standing. And hence, they force these individuals to go ahead with the marriage. And also fear of shame. Some families fear the stigma of a broken engagement or marriage over genotype, especially if preparations and public announcements have already been made. Then it's a no, you will definitely get married. And also the desire for grandchildren. For older family members who downplay the risks of having a sickle cell baby, they force these couples to have children despite the potential health complications of sickle cell disease. And also from society, there's the fear of being judged. Breaking off a relationship or an engagement due to your genotype might be seen as weak or selfish or even overreacting. And also the fear of gossip from the community. People fear what others will say about them, which can pressure couples to go through with unions despite any medical advice they may have received. And also expectations around age and marriage, especially for women. There's often pressure to marry by a certain age for a woman. And because of this, there's the fear of having to start over or becoming labeled as being too picky. And this pushes them to go ahead with marriage and end up having a sickle cell baby. And also religious bodies, they believe in divine intervention. Some religious communities encourage couples to have faith and believe that God can prevent the birth of a sickle cell child or even cure the sickle cell disease. I'm not here to dispute that. I'm just telling you the pressure that these couples face. And also moral judgments. Some faith leaders or pastors or even the members themselves might see genotype-based decisions as lacking faith or being driven by fear, and hence will pressure couples to trust God and proceed to marry. And doctrinal stances on marriage. These religious groups may discourage breaking off engagements or marriages, no matter the circumstance, and hence promote endurance and faith over medical caution. Yeah. So I want us all to imagine this. You're engaged to the love of your life, and then both of you go to the hospital to test your genotype. And after that, you find out that you are both AS. What would you do? Would you proceed? Would you break it off? Or you consider other alternatives? I want to know your answers, please, right now. What would you do? Would you proceed, break it off, or consider other alternatives? Please let me know in the comment section. Okay, I can see them. Okay. Someone said on God. Okay, thank you. Oh, next slide, please. So for those who would like to look for other alternatives or even proceed, these are options for couples at risk. There's genetic counseling, where you seek professional advice and risk management. These are advanced fertility treatments designed to help couples that are at risk. There is IVF plus pre-implantation genetic diagnosis. For the IVF, it's just in vitro fertilization, where eggs are taken from the woman and sperm from the man, and fertilization is done in the lab. And for the pre-implantation genetic diagnosis, this is where the embryos are implanted. But before that, they'll be tested for the sickle cell gene before they'll go ahead to implant them. If the embryo is without the sickle cell gene, then the implantation is done. However, I would like you all to note that this option is very costly and is not widely available. Yeah. And there's also adoption. Couples can choose to adopt a child rather than risk passing the sickle cell disease. This ensures that they can still raise a family without this genetic risk. And also choosing to remain child free. For some couples, after the counseling section and personal reflection, they may decide not to have any biological children at all. And this is valid and brave. And I actually admire people who decide to do this. in order to avoid any genetic risks and health concerns. And also honest conversations before marriage. This is the most crucial part. You should talk openly about your genotype status before engagement or marriage. You have to discuss future plans, expectations, and the possible outcomes as well. You have to avoid surprises and difficult dilemmas later. So talk about it. It's a preventive measure before any decision making. Next slide, please. So our key takeaway message from this presentation is that know your genotype before making your life decisions. AS plus AS marriages carry real risks. Love alone isn't enough. There's wisdom and planning. So AA plus AA is excellent. AA plus AS is good. AA plus SS is fair enough. AA plus AC is also good. And AS plus AS is very bad. ASSS is also very bad. ASAC is bad, but some medical advice can be given to you. And SS plus SS is also very bad, same as AS, AC plus AS. And AC plus AC is also bad, but we can give you some advice. Next slide, please. So our closing remarks. Get tested, make informed choices, share this knowledge with friends and loved ones, and take responsibility for your future family's health. Thank you all so much for your audience. Thank you all for having us here. And thank you to RTC Foundation for having us. Thank you so much, everyone.
Thank you very much, Ms. Joyce. Kofi Adam from the comment section said that some love is difficult to break. It's true, actually, but that doesn't mean we shouldn't make informed choices. Okay, so moving on, we'll move to our question and answer session. Thank you again to all our speakers for your rich presentation. We really appreciate it. Now we'll take some questions from our audience, please. You can raise your hand or type it in the chat box and we'll read it out. Whilst we are waiting on the audience, I also have a personal question. Ms. Joyce, please, is genetic counseling available in Ghana? And if it is, how can a couple access it? Hello? Please, there's a question. Is genetic counseling available in Ghana? And if it is, how can one access it?
Hello, Sarah. Good evening. Can I come in?
Yes, please, you can.
All right. Thank you very much. So yes, genetic counseling is available. Many times, churches do very well with genetic counseling, meaning that for most churches, when you come together that you want to get married, as part of the premarital counseling, you have to go to the hospital and get checked. So you do your genotype. It's not just about sickle cell, there are other conditions as well, HIV and all. So the church requires you to do all those labs, all those tests before they can proceed and say, okay, you can get married. So in the course of the testing, if something is found, then based on that, the church will get special counselors for you. So it is available. As I said, it is very much in the churches that we notice it. But if two couples are coming together and they want to, let's say, take seed or get pregnant, or they want to do their labs and do their tests before pregnancy or before marriage, it is available. You can go to any facility that you want to go to, and then you just ask them. Many times, some private facilities may have an organized service for you, but for many public hospitals, you just come to, let's say, the obs and gynae, and then they can take you through that. Or antenatal, we have something called preconception care, before pregnancy care. So that one too, they can do your labs for you. So it is very much available, and it is really seen in the churches. So we would really commend the church facilities for doing it very well for the premarital couples.
Yes,
Thank
please. Thank
you.
you very much. Thank you too.
Can I also share my part?
Yes, please.
Okay, so other than the churches, the the um there are genetic counseling, right? But then they are not widely accessible across the whole country. It's still growing. There is one known as the Genesis, which is the Genetic Education and Counseling for Sickle Cell Condition. It is a short online course developed by the University of Ghana's West African Genetic Medicine Center in partnership with the Sickle Cell Foundation of Ghana. This organization, it equips health professionals like the nurses, midwives, and others, and even psychologists with the skills to counsel families about sickle cell disease. It is delivered in the University of Ghana campus, the Accra. Yeah. Thank you.
Oh, okay. Thank you very much. Please, we have a question from Doreen. She's asking, if you are both AS and have 3 children, can they all be SS? Please, anyone can take it.
Okay, let me take it. So thank you so much, Doreen, for the question. With every single pregnancy, as my colleague Miss Millicent mentioned, with every single pregnancy, there is a 1 in 4 chances. That is 25% chance that that child would have a sickle cell disease. So if you are not fortunate enough, and then for your first pregnancy, the child turns out to be part of this 25% chances, and then you give birth to a child with sickle cell disease. Your next pregnancy, the same can happen. So yes, you can have 3 children with all of them having all the 3 of them having sickle cell disease. Likewise, you can have 3 children and all of them will be normal, because the risk goes with every single pregnancy. It doesn't mean that when you have a sickle cell disease, then that means the rest of your children are going to be normal. The risk comes with every single pregnancy. So to answer your question, yes, all 3 children of yours can have sickle cell disease.
Thank you very much, Miss Aisha. Please, are there any questions? Any more questions? Okay, Chikata Beatrice Edinam is asking, please, does this condition has any relationship with nutrition or diet?
Okay, so from my research and then from what have been taught in school, nutrition doesn't have anything. It is genetics. It has to do with genetic mutation. It goes down to the genes, our genes. So nutrition does not have anything to do with this. Thank you.
Okay, I have one last question for myself. How does AS status impact one's mental health in a relationship?
Okay. Can I take it?
Yes, please, you can.
Okay. So for the AS, the most important thing when it comes to AS is choosing the partner. That is the whole point. So if you know that you are AS, the major advice that you always carry across is when the person takes your number and you start talking and you feel like this thing can go somewhere, you have to ask the person's You have to ask the person's sickle cell status so that you don't go deep into the relationship and in the end up being disappointed because you find out that your partner might be AS or not. Because if you do that, that is when your mental health will be affected. Not that the AS itself is going to affect you, but the the knowing that your partner is AS when you've invested more in the relationship will lead you to having these kind of mental issues when you find out. Thank you. I don't know if I've answered your question.
Yes, please. I'll let my partner know. We would both go and check so that we know our sickling status before it gets out of hand. Thank you very much, doctor. Please, we have another question. Can a sickle cell patient go into anemia? One of our speakers can take it.
Sickle cell patients mostly go into anemia. They usually have, I think this person came in late. So they usually have their red blood cells, the abnormal red blood cell. As I mentioned earlier on, it's very fragile. So it easily breaks. So when it breaks, when the red blood cells break, there is going to be anemia, which is low hemoglobin, the protein I mentioned earlier on that carries oxygen to the tissues. Whenever we have low hemoglobin, lower than the normal, this condition is known as anemia, and it presents with a lot of fatigability. With little activity, you are going to be fatigued. You are going to get so exhausted as if you've done something strenuous. Thank you.
Thank you very much. Please, are there any more questions?
I have a question.
Please go ahead.
So my question is to Aisha Mustafa. So I want to know, how can AS carriers monitor their health even if they don't have the disease? And then also I think to the last speaker, I think she mentioned about IVF. So I want to know, is it something that is very common in Ghana? Yeah, thank you.
Okay, thank you very much for your question. So AS, I mentioned earlier on that the carriers or the traits do not have symptoms. However, in certain instances, which is very rare, when they are exposed to certain situations like low oxygen tensions, or they do intense physical exertion, they go through like intense physical exertion, or they go through major surgery, they can have their red blood cells getting sick because they have the gene. Just that because the genetics has to do with, because it's in autosomal recessive form, that is, you have to get the gene, the abnormal gene from both parents before you become you have that disease. But if you are exposed to certain conditions, as I mentioned earlier on, you can have a sickled red blood cell. For example, such patients, what should you do? What should you do to monitor your health? You have to prevent dehydration. Dehydration can make an AS patient have a sickled red blood cell and then go through what the sickle cell patient goes through. But then this is very rare. So you have to prevent dehydration as much as possible. And then before you go into a major surgery or anesthesia, make sure you inform the anesthetist or the doctor. Tell the doctor you are AS. They have certain things they do. They have certain assessments they do, and then some preventions, and then giving you IV fluids and all these things that doctors know about. So when you mention it to the doctors, they're going to be very cautious and do the necessary things to prevent you from getting anemia and the symptoms of the symptoms of sickle cell disease. I hope I answered your question. Thank you.
Thank you very much, Miss Aisha. Miss Joyce, please, he had a question for you.
Yes, about the IVF. IVF is quite common in Ghana, but for the pre-implantation genetic diagnosis, it is not very common in our part of in Ghana here. However, this is also very expensive, both the IVF and the pre-implantation genetic diagnosis. That is exactly what will tell you whether that embryo carries the sickle cell gene or not. For IVF, you can have the baby, but for the pre-implantation genetic diagnosis, this is where it tells you whether that baby will be a sickle cell baby or not. I don't know if I've answered you.
Yeah, thank you. Um, I think Dr. Benedicta was mentioning that during when she was talking about the church service and stuff with so I wanted to know, so in the era of falsification of lab results and stuff, so how would you handle, like, assuming your partner, in order not to lose you, actually falsify lab results and then you later find out after being married? What's the best approach to handle something like that? Thank you.
Okay, you are asking in a situation where you are both AS and you're already married.
For example, yes, and then like one partner falsifies document in order to show you probably A on lab results, but then in reality you're actually AS. So therefore you falsified your document to be AA. Now you've gone ahead, you've married, and then later, me being the man, I found out that, oh well, this is what my wife did. How should I handle such situation?
So for such situation where the couples are both careers and they are already married, that is where I mentioned the options for couples that are at risk. There's the adoption, choosing to remain child free, the IVF and the PJD that I said. All these are options if you still want to continue with the marriage. These are things that these couples can do in order to avoid having the sickle cell baby. Please, have I answered you?
Yeah, thank you.
You're welcome.
Thank you very much, Ms. Joyce. We'll take our last three questions from the chat box. A call is asking, so can the carriers also take hydroxyurea to prevent any form of complications? Anyone can answer, please.
Okay,
Our
can I take it?
speakers.
Oh, it's
Sure, dog, say.
Please, the hydroxyurea is not for carriers. It's only for those with sickle cell disease. So, for that side, no one is supposed to take even with the sickle cell disease patients who have SC and stuff. Sometimes we even have to be very sure. Most of the times we give it to the SS people in Ghana currently, except the SC person is also having some form of crisis. But if you are AS or AC or any of the carrier genotypes, you are not supposed to take hydroxyurea. Thank you.
Thank you very much. Our next question is, can a sickle cell patient who has anemia take iron supplements or food rich in iron? Or it depends on the type of anemia they might have?
Okay, let me take this one. So sickle cell patients with anemia, yes, they can take iron supplements. Now, not just iron supplement, because your red blood cells are damaging. They are breaking down. You need things that will make more the bone marrow to produce more red blood cells. And then iron is one of the nutrients that are needed. We have folic acid as well. We have vitamin B12, all these. So they are very necessary to take, especially the folic acid.
Thank you very much, Ms. Aisha. Our last question from Doreen. I learned the results can be wrong sometimes. How often can we check to make sure we get the right results?
Okay, I'll take this one as well. So the results, yes, the results can be wrong, just like any other test. There could be system error, right? So it doesn't mean that the wrong results have anything to do with just the checking of the genotype. So any result at all there could be any mistakes. So I think at least two. So if you have the results, you do it and then you get the results and you are not certain, you can do it one more time. And if you have both results having the same, both tests having the same results, I think you are good to go. Thank you.
Okay, I'd like to add on. Usually, most people, there's this rumor that your genotype can change. Your genotype never changes. A good test done once should be able to tell you your genotype. However, you can test as many times as you want to be sure, but your genotype does not change. Yeah, that's what I want to add.
Thank you very much.
Moderator, I wanted to add something.
Please go ahead.
I think in the course of the discussions, a lot of options were given with regards to how couples and stuff, couples can address issues concerning their genotype when they are AS and the partner is also AS. And from my little experience, I would like to say that all these options are available, but peace of mind is very important. It will surprise you to know that if you don't take care and you go and give birth to an SS patient, the love between sometimes the couple even vanishes. Most of the times, the women spend most of their times in the hospitals. You can be visiting the hospital like 3 times in a week and stuff. With regards to a patient being sick, the best decision you can ever do for yourself with regards to this sickle cell is to terminate the relationship. You shouldn't follow love, just as Joy said. If you follow love and you go and date somebody and you think like you have options, options are very, very expensive and it can fail. If you go and marry someone else and give birth to SS, the love will vanish when the children start getting crisis because you might not, your partner will even leave you. Thank you very much.
Thank you very much, Doc. Before we end this lovely webinar, I've really enjoyed the discussion and I hope our audience did same. We have our president with us, and I'd like to invite her, Dr. Benedicta, to share some brief closing remarks and reflections.
Hello, Sarah. Thank you so much. I have really enjoyed the session, and I must say, I am always impressed, intrigued, humbled, especially, and most honored when I see that our presenters put in so much work to have these presentations. And I must say that you ladies are incredible. I really honor you. I appreciate you. Thank you for the hard work that you put in this. From the bottom of my heart, I want to say thank you. And before we end, I would also like to add a few experiences, share a few experiences with you regarding the disease. I've been to the pedics, I've worked with the pediatric setting for about 6 months. And I saw some cases that I would like to share my thoughts on so that some people get the real story or they have a real experience of it. So I'll start with the results. That is my personal story. So one said that the results can change. Truly, I would have said the same thing because I first checked. This is something I'll freely share with you in my family. My mom's side, there is a sickle cell trait. I have cousins who have the sickle cell disease, and it is not a joke. I mean, when they have crisis, sometimes you want to help and all of that. So this is also very personal to me and something that I also experience. Even though I do not have the disease, I said some of my cousins do have the disease. I had always known that there's this trait in my family. So I remember there was some health screening, and then I decided to go and check my genotype. I checked, and then it came out as AS. So it was something that said, okay, since it's in my family, I mean, it's okay, I'm AS. I mean, I accepted it until I went to Konfanochi Teaching Hospital, and then one of my friends was at the lab, and so one day she was like, she wants to learn how to take samples and all. She took our samples, my roommates and I, and then she came back, and then it was AA, and I was like, really? Is it as my genotype has changed or what? So I was like, no, I've always known it to be AS and I've accepted it. So why AA now? And then so I told her to repeat the lab, and then it came out again as AA. I would have given a testimony that God has changed. God has changed my genotype. Probably God changed, but also in the realistic, sorry, not that God is not realistic, I apologize, but in the science setting, or let me be as layman as possible. The truth is that if you don't go to a very good lab or a very good lab service or center, you may have wrong results. So borderline, whether it has been changed or not, go to a certified lab where you know that their results are trusted. That one, you will have good results. The last one I would like to share is that I have had instances. I will share one personal story with you during my lectures. My lecturer told me of spoke to me over a story of two doctors. I think no, one was a doctor, one was not a doctor. And then I think unknowingly they got married without the knowing that one is AS and the other is also AS. So they gave birth to the first child. The first child turned to be AA. So when they got to know, it was too late, according to them, for them to break the marriage. They gave birth to one child, the child was AA. Second child, the child was AS. So in their minds, they were thanking God that, oh, we are both AS, but none of our children SS. They gave birth to their third child, and the third child became SS. And that's, when you immediately have the SS, you know that it's a long period of pain that you are going to endure. I had one client who came, her first child with her husband was SS, and you could see the love that the mother had for the baby or the child, but then you can see the suffering, that she was also experiencing. And now what she said was that the husband or the man is losing interest in the marriage and he's looking elsewhere, right? So you can, as Dr. Isaac said, you can have all the love that you have with your partner and all of that. But once you start experiencing that sickling disease, because when your child is having you, you have to bring the child for clinics. The child will be receiving blood transfusions. We always tell you that bring blood, because if the HB is low, what the child need will be blood. So bring blood, bring blood, bring blood. And then the child will be having crisis upon crisis. You'll be chasing medications. So the bottom line is, when you, as Dr. Isaac said, when you get to know that this person, I am likely getting interested, and you are SS, is good for you to even just admit, or it's good for you to let the person know, so that you can prevent, so that you can help one another. This is a funny story. Someone just texted me, was like, hello, what is your genotype? I texted him and he was like, you are AA, I'm AA, let's get married. That's on a funny side, but I like the intellect that the person showed, that before we do anything, or before I express any interest in you, I have to know what your genotype is. So the bottom line for us is, you may try and say that God can help me. You may be lucky with this lecturer I told you about, who first child not SS, second child not SS, but third child had SS. And I mentioned one to you, her very first child SS. So you can't really play cards. In as much as you believe in God, God has also given you wisdom. God has also given us knowledge. So you can't downplay wisdom. You can't downplay principles in life and blindly say that because I love, I am going to follow. You can decide to do that, but you always bear the consequences. So on this note, I want to say thank you all for joining. We pray and we hope that you have learned something worthwhile that you can take with you and also share with other people who were not on it. Put it, when your family member goes through the disease, when you see someone suffering, that is when you feel that this is something I never want to experience, or I never want my child to experience. So we have said enough, we have shared, we have learned, and we have had fun. I hope that all of us will pay heed to whatever has been shared here, so that we don't meet you in the hospital. Thank you very much.
Thank you very much, Dr. Benedicta. It's sad, but all too soon we've come to the end of this impactful webinar. I would like to express my sincerest gratitude to everyone here, our audience and our president, Dr. Benedicta, and our wonderful speakers, Miss Aisha Mustafa, Miss Millicent Ajiman-Bidu, and Miss Joyce Aframa Samuel, for sharing their knowledge, passion, and personal insight on this topic. Today's conversation has shown us that love must walk hand in hand. And as Dr. Benedicta said, God has given us the knowledge. Let's use it right. Let's continue to educate others and support each other so that we make informed choices, because it would be sad to have a child who has the disease. Thank you all so much once again. And please enjoy the rest of your day. But before we go, we will take our closing prayer from Dr. Isaac. Dr. Isaac, please pray for us to end the session.
All right. We thank God for how far He has brought us, for the knowledge that we've obtained. We pray that the Lord lead us and guide us to take best decisions that will not lead us to have these other health implications. And we pray that the Lord will help us educate our friends, family, so that in the end, the goal of eradicating this disease can be achieved. In Jesus' name, I pray thanksgiving. Amen.
Amen. Thank you all so much and have a lovely day. Bye.